Hello, this is Tea Time with Quest Care. I am your host, Dr. Nilda Lopez, and thank you so much for joining us today. Basically, hurry up, go get your cup of tea.
Absolutely, we have ours.
and join us, okay?
Yes.
We're excited today to be here. My name is Dr. Nilda Lopez. I am a family medicine doctor and I specialize in geriatric medicine. I work at the Quest Care Medical Clinic in Capel. Today, I'm very excited to have my guest speaker here, Dr. Jyoti Bharti.
Hi, everybody.
She's amazing. She currently practices here with me in the Quest Care Medical Clinic at Capel. She's a great friend and my colleague, and so we have fun together when we work every day. Dr. Bharti is a board-certified family medicine physician, and she also specializes in geriatric medicine. She received her bachelor's degree from the University of California. She further completed her medical degree at the American University of Antigua College of Medicine, followed by a family medicine residency program at St. Elizabeth Medical Center. Dr. Bharti, she's very respected among her peers. She's a great geriatrician. She's well loved by us and by her patients. She does amazing TikTok videos on the site, so you should check it out. She's very genuine, right? And she truly cares about her patients, and so she always tries to make sure that her patients get like the care that they need, and I really appreciate that. And it's a joy to work with you.
Same here, Dr. Lopez. Thank you.
Be around you. You always make work so much fun.
Thank you. It's my pleasure to be here and an honor to be working side by side with you.
Thank you. So please help me welcome Dr. Jyoti Bharti. So I want to thank all of you guys for joining us today and taking the time out of your day to tune in and be part of this program and listen to us. Also, please be sure to comment today. When you log in to watch us, please type in your name and say hello so we know that you're here. We will have a prize for you at the end of our talk. So you want to make sure that your name is there. So we'll write your name down and we'll give you the gift at the end, okay? I would like you to like it and share this talk that we do today. You can also be sure to share our video with your friends and your family, anybody, your parents, grandparents, everyone that you feel like will benefit from our talk today. And give us a great rating as well. And if you have questions while we're doing our talk, please type in your questions. I will read it and we'll try to answer it as we go, okay? Also, please remember that the information that we're discussing today is not giving you any personal medical advice. The information you get here is for your information and entertainment purposes only. Our topic today is depression in geriatric patients. I thought Dr. Bharti would be the perfect person to talk about depression in geriatric patients because she's a great geriatrician and we both practice geriatrics together, and so we treat this issue of depression in geriatric patients all the time. So Dr. Bharti, I want to share with you, so when about a few years ago, one of my friends' grandpa, he was suffering with like depression because his wife had died, okay? And basically he was having like these ups and downs, he had the initial bereavement episode, right? When somebody dies, it's okay to grieve, but then it just kept going on and hung on for almost, lingered for about like 6+ months or so. And we kept telling him, hey, you need to, go get this checked out, go get meet a counselor and try to see if you can see a doctor and get some treatment. But obviously he didn't believe in any of that. He didn't want to get help and get intervention. Very common. And so I would say like around about like 9 months, he started to, he would make comments like, "Hey, I don't think I want to live anymore." Like making like suicidal comments, like, "Oh, I may want to die," this and that, and the family just sort of like pushed it off, like just brushed it off, didn't make it a big deal, and a week later, he actually committed suicide and died. And that taught me a great lesson as far as geriatric patients are concerned. Because in geriatrics, when a geriatric patient says they are going to kill themselves, they actually complete the task. It is not like our teenage patients, our 17, 16-year-olds, when they say, "I want to kill myself," it's more a cry for help, right? For geriatric patients, when they say that, they actually want to end their life. Absolutely. And so we have to take it absolutely seriously and address it. And so that was a traumatic thing that happened to their family. And, ever since then, I've just been very, very conscientious and aware of everything that goes on when a geriatric patient says, "I'm depressed and I'm suicidal," and this, and I take it very seriously. So I want you to tell our audience today what is depression and what is it about in geriatric patients.
So once again, thank you for having me today. Quite an honor to be here talking to you guys about depression in geriatrics. A very, very common problem we see is depression, clinical depression in our aging population.
Have you speak up a little bit more so
sure.
they can hear?
So geriatrics and depression, a very common problem that we see in this population. Normally we know the term that depression is feeling blue and feeling sad, but it actually is a very serious mood disorder. A lot of time in geriatrics, this does not come out as to be very typical as well. The presentation is very atypical compared to what we see in our younger population. There are so many things when you were presenting me the scenario kind of made me think, yes, that's a very, very typical geriatric patient coming to you with depression. A very big risk factor for depression is the loss of a loved one, the grieving of the loved one. And like I mentioned, that it's not only just feeling blue or sad, it actually starts affecting your daily life-to-life activities. You're unable to focus on your daily activities. Your mood disorders are seriously affecting your sleep, your eating, your hobbies. Your family starts noticing that your mood has become irritable.
They stop eating. They lose weight.
Start becoming. Did we lose anything here?
Can you check, Maddie?
Yeah.
I think we're fine.
We're fine. Okay. So and that's what the clinical depression is. That it's not just feeling blue or sad. It's when it starts affecting your daily life-to-life activities. It's when you need to address it immediately and get treatment.
Yeah. And depression is huge.
It's huge, and
in geriatric patients,
absolutely,
it really is.
I wanted to add to that it's a very common problem today. If anything you get from our talk, do know that geriatric and depression is a common problem, and please do not consider it as a normal part of aging. It's not a normal part of aging. This is a very common problem, and we want to, as my goal and Dr. Lopez's goal is, to address this and get help for my community, for our geriatric population.
Thank you for saying that, Dr. Bharti. That was very well said.
Thank you.
And if you're just now joining us, this is Tea Time with Quest Care. I am Dr. Nilda Lopez, and my guest today is Dr. Jyoti Bharti.
Hello.
And we are discussing depression in geriatric patients. I would say, Dr. Bharti has described exactly what depression is, poor sleep, appetite, etc. Sometimes people having suicidal, homicidal ideations, just their mood being down. And in geriatric patients, how do we screen when they are depressed? There's something called a geriatric depression scale. Okay. Okay.
Sorry.
We lost connection there a little bit. We fixed it. And so we typically take depression scale to screen patients. also there's something called PHQ-2 and a PHQ-9 that we use in the clinical setting commonly. And there's other scales too that can be used to screen patients. PHQ-2 is the easiest one that we use. It screens for basically the top two cardinal questions that are in the PHQ-9, which is, are you having what we call anhedonia, like loss of interest in doing the things that... What do you mean finish? Is it working?
You're good.
Okay. Sorry, I think we're having internet connection issues and it keeps breaking. But to go back to what we were saying...
anhedonia.
So anhedonia, you lose interest in the things that you do, as well as person feeling depressed or feeling sad. So usually we screen with the PHQ-2, and if the patient is positive for any of those, then we move on to do the PHQ-9. We ask more extensive questions, and if you are depressed, then we try to find interventions to help you. So what would you say are the treatment options that are available for our geriatric patients that are feeling depressed?
So she mentioned beautifully anhedonia, loss in our pleasurable activities, our hobbies, and then feeling down and hopeless. Those are the cardinal symptoms. But normally geriatric patients will actually come to you asking and telling you that I have trouble sleeping, I have lost my appetite, and I am extremely tired. And family will actually come and tell you, he's grumpy all the time now. My dad was never like that. Mom's so irritable. She snaps at everything.
Yeah.
Those are some things that first you figure, get a hold of. And then second thing with the treatment, we want to rule out if there is any organic cause to your depression, because there are multiple other things that can bring on these symptoms. First thing is thyroid. I want to mention that.
Yes.
Thyroid, B12 deficiencies,
Yes.
anemia. Those are some very important diseases that can cause symptoms of insomnia, fatigue, and restlessness.
Look like depression.
And it can absolutely mimic depression. So my first thing is seeking help with your primary care provider. That's the first key to your treatment plan. Seek help, talk about it, and then the next sort of plan is we do a thorough physical evaluation. We do a thorough lab examination to rule out any kind of organic cause.
Yes.
And once we have ruled out that there is no sort of illness that can be mimicking depression for you, we then go ahead and start talking about medication therapy as well as talk therapy, commonly
psychotherapy, CBT,
Absolutely.
vitamin CBT, like we said last time.
Yes.
So there are several forms of psychotherapy, right? There's like music therapy, exercise therapy. There's regular, cognitive behavioral therapy. And so we try all those things. There's aromatherapy. There's so many different options of therapies that people can do that helps and it works, especially so depression is either mild depression, moderate depression, or severe depression. So I would say in patients with very mild depression, a lot of times psychotherapy alone will work, that they don't need medication. The times where we start to use medicine is for our moderate depressive patients or severe depression. Patients suffering with severe depression, they usually benefit from medication plus psychotherapy. So the combination of both, okay? And I think that it's also important to, when somebody comes and they're very depressed, we have to rule out like other things. Like I always ask, are you manic? Have you ever had a manic episode or a hypomanic episode?
Other psychiatric illnesses.
Yes, exactly. Because it could be that.
Absolutely.
It could be bipolar disorder. So then you treat the patient for depression for 6 months, they don't get better. That's like treatment-resistant depression. And we have to figure out what's causing this and figure out what the issue is. Sometimes, drugs, people are on drugs. It doesn't matter how much antidepressants I put you on, it's not going to get better. They, just because someone is 75 years old doesn't mean they're not using cocaine or heroin, right? You always have to look into that, because sometimes back when they were younger, they used to use heroin and they never stopped, you know.
Absolutely.
And so it's critical that we ask all those questions.
Which is why a thorough physical evaluation and examination is important in the diagnosis of depression in geriatric population.
In a geriatric population. And is it a neurocognitive cause, a neurodegenerative disorder like an Alzheimer's dementia or something that's causing you to present as depressed? Like when I think of an Alzheimer's dementia patient, you know, they have all those plaques and tangles in their brain, right?
Yeah.
And so, if you have all those plaques and tangles in your brain, it can cause you to become depressed because the brain controls everything. It controls your mood.
You're unable to do your normal activities like you do. As you know, severe depression, severe dementia can lead you to lose your simple activities of chewing your food.
Yes.
They are unable to chew food, unable to swallow, unable to use their
and that
hands
even makes you depressed.
Absolutely,
and
losing your activities.
Yes, and to talking about chewing and things like that, I've seen some of my elderly, my old patients, you know, as you really age, you lose your sense of smell. Sense of smell, sense of taste, right? Yeah. So they can't even taste or eat their food. So they stop eating and they start losing weight. They actually need help. We have to get caregivers to feed them and remind them to eat and all those things that, you know, are important. Sometimes my old patients, they will be eating spoiled food. They can't even tell. They don't know
because of the loss of smell.
Exactly. Yes. And so all of that makes you depressed. I mean, you don't appreciate those things when you're younger, but as you age and you become really old, because we take care of the very old, right?
Absolutely. we are very senior population in our family.
Doctor. I mean, we still take care. We still have our babies, our 2-day-olds that I love.
We have our youngsters. We have our infants. We have our toddlers. But we also have a very big population of our geriatrics.
We do have, And Dr. Bharti worked in the nursing home for 3
years, 4 years before I joined Quest Care.
You're very used to taking care of chronically ill patients and patients that are on hospice and palliative care and patients that are dying. And so she has significant experience.
That's the reason I decided to be a geriatrician. I felt that it's something, a field like geriatrics requires a little extra passion.
Yes.
A little extra set of eyes and care to bring upon in this field. Not everything is just depression or part of aging. I always tell family members, please do not consider it normal aging until I say so. Let me do my diagnosis, let me do my workup, let me do my physical evaluation, and we go from them. And depression is one of those diagnoses where we need to do a very thorough evaluation and a very thorough screening before we come to that diagnosis. And it's a very serious kind in this population. We are in a pandemic right now, and I am seeing multiple geriatric patients at the moment who are suffering from clinical depression. And one of the biggest reasons is with this pandemic is social isolation, unable to connect with our loved ones, the loneliness, the loss, and the grief from not able to connect with everybody. It's a very big risk factor for the geriatric population at the moment.
Very significant.
Very significant. And so my biggest advice to the family members today is please stay in touch with your elderly. We are in 2020 with a beautiful technological advancement.
Zoom. Everybody's on
there
Zoom.
There we go. Zoom. Hey, if you don't know Zoom and if you're not computer savvy, that's okay. Just press FaceTime.
Oh, FaceTime. That's the easiest way to do. Just FaceTime.
The point I'm making here is for the family members to please check up on your elderlies, whether you can do that via FaceTime, whether you do drive-by, but use your technology. Send them a text. Hey, how are you doing? Are you feeling okay? Because like I mentioned, social isolation, loneliness, loss of this is a very big risk factor of depression, and we are seeing that quite a bit currently with our population. And I hope with this talk I can get this message out that definitely check out on your elderly. Use this work, this technological advances to help and look out for them, talk to them. Sometimes all it takes is a text message to bring a smile on and a quick wave hi on the FaceTime.
Exactly.
So definitely do that. Give them that something to look forward to for them.
And I would say if you're just now joining us, this is Tea Time with Quest Care. I am your host, Dr. Nilda Lopez, and our guest speaker here today is my colleague and friend, Dr. Jyoti Bharti, and she's a geriatrician as well as myself, and so we're discussing depression in geriatric patients. And so I guess I would say, so what is the best way to choose an antidepressant for a patient? If someone comes and they are, you assess the patient, you've done your physical exam, you've done all of that, right? Your labs, everything, and you've seen all your labs are negative, and you diagnose the patient, I would say, with like moderate depressive disorder. For me, if a patient is like already on, if they've been on Zoloft before in the past, like they have a history of recurrent depression, then I just continue the old medicines they were on. Do you do a similar thing?
I do that. I also try to choose a medication that has the least amount of side effect for them.
Yes.
We try something called augmenting the therapy.
Yes.
So then once we have maxed out on a dose of a medication, we try to add on to that medication.
Yes.
But one of the biggest treatment plans, and I'm sure you agree with me, Dr. Lopez, on this, that
Yeah.
medication is one part of the treatment,
Yes.
but cognitive behavioral therapy is another part of treatment.
Yes.
And to make sure both of these treatment works is the social support for the patients, having a family support with this patient.
Yes.
All these three together gives a very,
Right.
very good treatment plan for a depression in a geriatric population. So the medication wise, sometimes one medication, one SSRI is not enough.
Yeah.
And we need to sometimes add a medication to
Yeah.
it. Sometimes we have to completely change the old medication, bring on a new medication. And like she mentioned, we have other psychiatric disorders that can be coexisting with depression. So we have to adjust those medications too. Keep in mind that patients with chronic illnesses do get depression very frequently. So we got to control those illnesses as well. And so when we choose medications, we make sure that their other illnesses doesn't get affected by the treatment
Because
plan.
most Jerry patients have they have kidney disease, a lot of them will have
diabetes.
liver disease. They have so
Yes.
many chronic comorbid conditions. And
Yeah.
most of our patients, our Jerry patients, are like on 20, 30, 40 drugs, right?
Absolutely.
Because by the time if you live long enough, you live to be 85, 80, 90, you've seen so many doctors in your lifetime that the medicines just start piling up. And I think what we do a good job as geriatricians is we are able to cut down.
Yes.
On the first visit, we get rid of half your medicines.
Absolutely.
We try to cut down, and they take a bunch of supplements and
Yeah,
over-the-counter things too. And we try to get rid of all the things you don't need because being on multiple meds, people become more drowsy. They sleep more.
Absolutely.
They don't get up and move around. And what geriatricians do, we want to get our patients moving. We want them to get off these medicines so they're not sedated.
Absolutely.
And so that's why you need to come see a
Absolutely.
geriatrician.
So that's why. So like I mentioned this before in the meeting, and I'm going to say it again, that very important is that if you sense that this might be a little bit towards depression, please come to your primary care. Please get it evaluated, because it might not be just depression, but sometimes it could be that, and it will need serious treatment, because it is not something that we snap out of it. You need medical treatment, you need therapy, you need social support along with all this to help better. And the reason why I say see a geriatrician, because we actually take into account your other illnesses. I have to make sure that I don't give you a medication that will not interact with your other pills that you already need as well. So we try to help you combat this disease safely.
And thank you so much, Dr. Bharti. We're out of time. I know we have so much to talk about.
This is a vast topic.
Yes,
there might be a sequel to it.
So I would say, if you would like to come continue this conversation with Dr. Bharti or myself or any of our Quest Care doctors, I want you to call us at 214-712-2054. Again, you can call us at 214-712-2054. That is a number that you can make an appointment at, okay? It's a general number for all the Quest Care medical clinics. You can also go to www.questcaremedicalclinic.com. We do have 11 clinics in the DFW location, and so in most places in DFW, there's a Quest Care clinic near your area. And so if you are listening to us today and you're thinking that you are feeling depressed, this is me, Dr. Lopez, Dr. Bharti, you're talking to me. I would like you to go and make an appointment and call this number, okay? And reach out so we can help you, right? Because action, you need to act. You need to act. Action is the only thing that works.
Right. And if you need me or Dr. Lopez, we are at Quest Care Coppell. Our number is 972-906-9130.
Perfect. Thank you for saying that. I want you to take action today. Pick up the phone, call the number that Dr. Bharti mentioned as well, okay? So think about if 3 months from now you feel better, you no longer feel depressed, you're able to be more functional, be able to enjoy your grandchildren, your family, everything, your quality of life is much better. You're able to do the things that you need to do, right? That is what treating your depression will do for you, okay? And so I want you to take action today. If you've heard us talk and if you feel like anything we've talked about today helped you, share it with your family, share it with your friends, share it in your, everyone that you can think of, and make a comment on our page, like our video and share our video, okay? I would like us to do the raffle, so if you bring it here so we can choose a winner because we're out of time here. See. Okay. LP. So LP is the winner. All right. Hey. So big hand clap. But thank you so much, Maddie. If you bring me the gift that we have right there. All right. So LP, we do have a gift for you. Our team will be contacting you today, and so thank you so much for taking the time to join us today, and I really appreciate you. I appreciate everyone for listening.
So thank you, Dr. for having me. Everybody stay safe.
Yes.
Give your elders social support.
Yes.
Virtually.
Yes.
Mask on. Stay safe.
Stay safe.
Thank you.
Thank you. Bye-bye. Thank you. God bless you.